All right, looks like it's 8 o'clock, so we can go ahead and get started. Hello, my name is Olivia Snyder. I'm a rising fourth year medical student at the University of Iowa, Carver College of Medicine. I've been doing virtual rounds for about a year now, and it's one of my favorite activities that I do outside of med school because I love teaching and I love doing the little mentorship at the end with you guys. So, um, this is also going to kind of piggyback off of last week when we talked about breast cancer, a little bit more of a deep dive into the pathology of that. So, today's topic is pathology of neoplasms. We'll learn all about like what that means and what the different types are and how they happen. But in short, neoplasms just means like tumor, and that could mean cancer or could not mean cancer. So this is a really interesting basic science topic and something that is definitely clinically relevant. And yeah, I think is really, really cool as well. We get a lot of requests for cancer topics. So hopefully this will kind of be a comprehensive one. Hopefully you're able to pull up your SOAP note and quiz. If you're having any difficulty with that, let me know and I can repost the link. But today we'll start with doing a patient case. We'll do it's going to be pretty brief because really the focus today is the pathology lesson. And then we're actually going to go through the assessment and plan after we do the pathology lesson so we can kind of apply what we've learned to the patient. Our goal for today is to have this session be really interactive and for you guys to be able to learn and have fun and get to kind of play being doctor. So if you have any questions or during times of participation, feel free to either unmute yourself or put something in the chat, whichever you're more comfortable with. So this is what our notes look like. Again, let me know if you have any trouble pulling that up. And these are not required. If it's your first time joining, you don't have to do these. It's just for you to get like a certificate at the end. Just had a nice little homemade pathology meme in here because this is so true. Like when you learn histology, which is the study of microscopic cells and tissues, and the practice of pathology is a lot of looking under a microscope and looking at these sections. Everything can just kind of look like pink and purple spaghetti sometimes. Or soup or whatever. Like it just is a bunch of cells that all look kind of the same and it can be very disorienting. So hopefully today we'll be able to show you guys some of these key differences here. But this is kind of a classic med student reaction to the histology slides. Okay, so we're going to start with our patient case. We have a 32-year-old female presenting to the OBGYN clinic today, and she has a chief complaint of pelvic pain and abnormal vaginal bleeding after sex. So again, because this is a pathology topic, we're not so much playing the OBGYN role, we're just kind of learning about the patient's history and to put our findings into a clinical context. But for the sake of the presentation and to kind of maybe do a little bit of a 2-for-1, oh, sorry. I meant to put on here, what would you guys think would be some causes for a differential diagnosis that we could include in things to consider for why she could be having this pelvic pain and abnormal vaginal bleeding after sex? Let's try to come up with at least like 3 things as a group. And they could be normal things too, like any other reasons why you might have vaginal bleeding, pelvic pain. Endometriosis, UTI, both of those are awesome, yes. Thank you, Mark and Adam. Cole saying depends how long after sex, if it's days or weeks. Ectopic pregnancy, exactly right. Yeah, these are all excellent GYN, genitourinary type ideas for things that can cause that. And I would definitely include all of those that you guys mentioned. These were just a list that I came up with and was too lazy to copy and paste the box over to start a new list. But yeah, Cole was right on track that depending on how long it is, it could just be like menstruation or spotting. If it's after, like directly after sex, maybe it's like a trauma or a laceration to the area, like the vaginal introitus. If there's not enough lubrication or if there's like, tearing, things like that. Pregnancy. Yeah, you can certainly have like implantation bleeding and you can have pelvic discomfort with pregnancy. Um, so far, those are all like normal or normal variants of just, not like super concerning things, but things that, you'd want to maybe draw attention to and address if possible. And then we have some more other like pathologic and scary things. Of course, like the big red flag that we'd not want to miss would be cancer anywhere in the female reproductive tract, like uterine cancer, cervical cancer, vulvar cancer on the external female genitalia, and ovarian cancer. Those can all kind of present with pelvic pain, possible bleeding, nonspecific symptoms. Ovarian cyst is another common one that people can have pelvic discomfort with, especially after sex. Depending on the type of cyst, it can be a hemorrhagic cyst. It can be just like a simple cyst. I don't want you guys to get too caught up in the details. And really, this differential is just to kind of work your brains on what are the different possible causes and to think about, well, yeah, I'd break it down by the timeline or like if it's right after sex or how long she's been having it and that sort of stuff. So we'll get some more details here in a second. Oh, and then just for clarity, endometriosis, somebody had mentioned that. That's abnormal implantation of uterine lining tissue, the endometrium, outside of the uterine cavity, in case you've never heard of that word before. And so it can cause pretty debilitating, heavy menstrual bleeding and cramping, usually around the time of the menstrual cycle. And then vaginismus is a kind of combined psychologic and gynecologic problem where the muscles of the vagina and the like genitalia are not able to relax during any sort of activity. So you can have like painful spasms or you can have difficulty with sexual activity. So just in case you hadn't heard of those words before. So a little bit more of our case details here. Our patient first noticed this bleeding after sex, and that can also be called postcoital bleeding, about 2 months ago. And she has been using lubricant, and that has not helped her problem. So that makes us think that, maybe this isn't like a mechanical trauma, tearing, that kind of a mechanism, which is common in a lot of women, and especially women who are postmenopausal, which this patient isn't, but, just something to keep in mind. She has never had this problem before. And her last pap smear was 6 years ago, which is a pretty long time. The guidelines currently are for people who are low risk during this age group, it's to get every 3 years, and even more frequently if you're high risk. This patient has 4 lifetime sexual partners with a combination of male and female. And depending on her practices, which it looks like they've used condoms inconsistently, that this would be behavior that we would deem higher risk. And so we would consider maybe even doing more frequent pap smears than every 3 years. So the fact that she's gone 6 years is definitely a red flag. And she has no pregnancy history, no obstetric history that we need to worry about. For her past medical history, she has had 1 episode of chlamydia. This resolved with a simple course of azithromycin, which is the first-line antibiotic for chlamydia. Her medications, she only has a progesterone IUD for birth control or intrauterine device. And she's had that for, let's just say she's had it for a long time. For her family history, she doesn't have anything significant or contributory. And for her social history, she works as a personal trainer at a local gym. So that's all kind of the stuff for the subjective section of the note. I know we kind of went through that quickly. And so if there's anything that you wanted to add or that we missed, then we can always go back if you guys need some more time with those slides. But moving on to the objective portion of the note, we're going to work on the physical exam. And again, this is more just to put our working knowledge into a clinical context. So I really just wanted to focus you guys in on the genitourinary exam here. I will just say that all of her vitals are normal. So I won't make us go through and read those. Unless you're curious, I can explain more about that. But all of her vitals are normal, and her entire cardiac exam, pulmonary exam, and abdominal exam are all totally normal. So no abnormal findings. For her genitourinary exam, we are seeing some scant bleeding at the vaginal introitus, which is the vaginal opening. She does not have any skin rashes or lesions on the vulva, which is important to look at and if we're considering something like vulvar cancer, vulvar carcinoma, that she doesn't have any visible evidence of that. And then her adnexa, which is the sort of part kind of in the pelvic area, but if you're palpating externally in the lower abdomen, kind of around where the uterus and ovaries would sit, that's the adnexa. And it's non-tender and does not have any masses. So that's reassuring to us that she doesn't have like any cysts or any like ectopic pregnancies. And then depending on where she's at in the menstrual cycle, you would maybe also have tenderness in that part of the exam if there was endometriosis, which we're not seeing. And then we're also going to do a pelvic exam and a speculum exam. So on the next slide, I'm going to show an actual picture of a cervix from a speculum exam. And so I just wanted to prepare you guys that this will be a real photo. So just for context, a speculum exam is where you insert a like metal tool into the vaginal canal and you kind of spread the bill of it open so that you can visualize the cervix. And it just kind of holds all of that tissue out of the way so you can have a nice clear view of it. It does sit kind of like right at the base of the cervix looking upwards. So if you have a patient lying flat and you're looking kind of towards their head, we're looking up at their, like the top part of their body here. And then what do you guys, I guess I didn't put a picture of a normal looking cervix on here, but just looking at it grossly, what observations do you have about this? Does this look healthy? Does this look abnormal? Yeah, Cole's asking if that's a laceration because we are seeing all that bleeding. It's looking really red and inflamed. Yeah, so I would say, I mean, the bleeding is a little bit more like spotty. It's not like a definitive cut that we're seeing. Maybe a little bit here that there's like this splitting of tissue open, but the rest of it, it just looks really like red and angry and just having random spots of bleeding. We're also seeing this border of this sort of like whitish looking, almost like a film sitting on top of the normal, healthier pink tissue behind. And it just has this really abnormal sort of rugged and irregular appearance to it. So that's definitely not a normal finding on a speculum exam that we'd want to do a further investigation into. So the OBGYN team decides to take a biopsy and send these for pathology for further evaluation. And then now, since we're the pathology team, we're going to work on reviewing the slide to make a diagnosis. So like I said, we're going to kind of come back to the assessment and plan at the end of the lesson so we can kind of work through our patient's actual slide together. Do we have any questions about the patient case so far? Again, this was just sort of for us to like build up our own knowledge base of what the patient is here for and what are some things that we'd maybe be concerned about. So at this point on our differential, I would be most concerned for cervical cancer or like a cervical precancer. And we'll kind of go through what the details of that would be in a few slides, but we definitely want to make sure that this patient is worked up thoroughly for potential cancer of the cervix. Okay, we'll keep going now. We're going to dive into our pathology lesson before we finish the patient case. So I wanted to also first define kind of what is a neoplasm, because this is a topic about neoplasms. And that wasn't a word that I had heard until I got to medical school. I had heard other things like tumor and cancer and maybe even benign in my pre-med and even before that. But I wanted to make sure that we're all kind of on the same page. So neoplasm just generally means new tissue. So this can be any mass of cells or tissue that's different from our normal healthy state. And this is something that we wouldn't necessarily have like as a normal variant from person to person. So like not just normal development, like you wouldn't call your like if you had an extra finger, for example, that's not necessarily a neoplasm because it's just like a developmental a developmental variant, I guess. But the important thing here is that neoplasm does not automatically mean cancer. It can include things that are benign, but we should always look into it further and consider cancer and not just dismiss things as being benign. So benign neoplasms, what's like the difference between them? Benign meaning harmless and not posing a risk to your life or to have like severe progression of disease. So the features of a benign neoplasm would be things like preserved architecture of the original tissue. The cells, when we look at them under a microscope, they have like a lower risk appearing morphology meaning like the appearance of the actual cells, their shape and size and how they compare to each other. We see minimal changes from the baseline tissue, and the cells are also well differentiated. They look like the cells from the sample that we took. So if we took a sample of the cervix, like a biopsy of the cervix, does it look like the appearance of cells that we would expect in a cervix, or does it look like a stomach gland or something? That would be really, really weird and probably not happen, but that's kind of what I'm getting at here. Examples of benign neoplasms would be things like colon polyps, a common mole on the skin, a lipoma, which is like a benign fat tumor sometimes that people have under their skin. That's again harmless and you don't have to take it out, but sometimes they bother people because they can kind of have this extra mass in a certain area. And then even things like skin warts as well. So those are all benign neoplasms, something that are not normally there compared to the surrounding area, like your normal skin or your normal colon, but they're not going to pose a harm to you. Whereas malignant neoplasms, malignant meaning cancerous and invasive and risking further progression of disease and causing potentially even death. The difference here is that it's an uncontrolled process and it's very high risk for spreading to distant sites like the lungs, brain, bones, liver, things like that, because they gain ability and behavior to invade blood vessels and travel to other parts of the body. You'll notice that when we look at some malignant neoplasms under the microscope, that they do have a abnormal morphology. They have significant changes from their surrounding tissue that we would expect, and they lose some of that differentiation. So they just look really weird and abnormal compared to what we would expect for that tissue. So again, just kind of what makes cancer cancer, because all cancer starts off as our own cells. They just are normal cells that happen to somewhere along the way have things go awry and turn into cancer. So it's not like an infection where you get something that's not you and not your own cells and human that is causing this, but that's what makes cancer so hard to treat as well, is because it really is just like part of our own bodies and our own tissue. So all neoplasms occur due to accumulation of mutations that cause problems with cell division, morphology, and growth. And that's really what the key thing here is, that we're losing regulation of cell division here. So some of those genetic changes can be activation of oncogenes. Oncogenes are things that are going to promote the cell cycle and progression to cancer. We could also lose protective genes called tumor suppressor genes. One that a lot of people know even as early as high school or college is P53. We see that mutated in a lot of cancers. Things that are mutagenic, carcinogenic, like environmental agents, things like certain chemicals, carcinogens. We find a lot of those in smoking, environmental, like, I don't even know. I'm doing a terrible job of explaining. Like, you guys know what like carcinogens are. Things that are bad for you, UV light, any other just general radiation, even if it's in treatment for another cancer, it can predispose you to a different type of cancer. So those types of things that are really harsh on cells and can cause mutations from the environment. And then also microbial factors. So certain viruses because viruses replicate inside our own cells and they sometimes integrate themselves into our own DNA in order to achieve replication, can alter our DNA and make them prone to mutations that can cause cancer. So one of these is HPV, or human papillomavirus. Specifically, strains 16 and 18 are associated with increased rates of cervical cancer. There's a ton of different types of HPV that cause warts on the skin and even genital warts, but those are different strains. The ones that are high risk, I think there's like 30 plus strains of HPV, like genetic variants of HPV. The ones that we're mostly concerned about are 16 and 18 in cervical cancer specifically. And sometimes just in genetic predisposition and inherited mutation. So you can have, like I mentioned before, P53 is probably the most well-known tumor suppressor gene. And if you have a knockout of one of those two genes, then you're losing already automatically half of your ability to stop cancer. So there's actually a disease called Li-Fraumenti disease, where you have a inherited loss of P53, and almost every one of these patients unfortunately ends up getting cancer in their lifetime. It's really sad. And it's very scary. And there's other germline mutations, like we talked about BRCA last week with breast cancer. So there's just a whole variety of these, but these are kind of all the things that make that switch from normal cells to cancer. Now kind of getting back to the background for our case. So I did want to also show you guys some normal anatomy and histology before we get into our pathology. So the epithelium is a cell type and cell layer that lines all surfaces of our body inside and out. Anything that's like, if you think of it being open to the outside world, is lined with epithelium. So that includes all of our skin, the mouth, the nose, the ears, your airway, breathing down into your lungs. All of your lungs is lined with epithelium. Your GI tract, so your esophagus, your stomach, intestines, and then rectum and anus all are lined with epithelium. And so just like, even though they're not directly in contact with the outside world, like hypothetically, it could, be in contact with things from the outside world. And so all of that is lined with epithelium. And the epithelium are layers of cells that protect and contain the underlying tissue. And they are basically this border here, the basement membrane, is what divides the epithelium from the underlying tissue, which is like connective tissue, stroma, extracellular matrix, things like that. But you'll notice, at least in this illustration, that the epithelium has this really nice organization of the cell morphology and shape that kind of transitions from like a more cube or like circular shape at the bottom with like more prominent nuclei, to having it be more like flat and spread out so that they can kind of pack on top of each other like pancakes. And that's what forms like the seal to protect your tissue integrity. Sometimes there's also a layer of keratin protein on top, especially if it's your skin. But throughout the rest of your inside of your body, you don't have as much of that keratin. So I'm going to show you guys what that looks like in a real sample here. Again, this is showing a normal section of the epithelium. We get that nice even layer of the basal cells here, and we don't really see it as nicely drawn on, but the basement membrane is what separates that layer of epithelia, of the basal epithelia, from the underlying tissue. And then we have these further like layers that are pointed out here. 4 is indicating like where the keratin would be starting to happen on this like top section. And these cells, they again just kind of progressively flatten out as we go higher. And then sorry, went too fast here. How do I get back? Sorry. If we contrast that with what this is called carcinoma in situ, or like a precancer, technically these cells we would call cancerous, but the defining difference is that they are not invading the underlying tissue. There's no crossing of the basement membrane. And so all of the abnormal cells are contained to that top layer. You can see in contrast with this normal section that we don't have any sort of nice organization. We're seeing all sorts of abnormal looking cells, like this one here has. Does anyone know what's like special about this cell? Like what it looks like it's doing? If you think back to like your intro to biology class, or maybe even Twilight, if you're a Twilight fan. Yeah, so Seema's saying it's in metaphase. It's in mitosis. So you're seeing actual chromatin indicating that the cell is dividing. And I would say probably metaphase, but you could make an argument for prophase as well. Kind of hard to tell, and usually the machine does a better job of telling than we do. But yeah, so like you're seeing the cell actively divide, and you're not normally supposed to see that. And some of these are like really tiny, and some of them are bigger, and they just don't sit well with each other. And so those are like really not normal findings. And the reason why it's obviously really bad if it crosses that basement membrane and becomes invasive, because what do you think these are right here? What are these two things? Blood vessels. Mark just got it. Yeah. So that if those cells cross into past the basement membrane and there's blood vessels sitting right there, then that's just a perfect way for them to start seeding and spreading to other places, because they can travel through the bloodstream to distant sites. So yeah, this is like a very scary looking precancer in the sense that it hasn't invaded yet, but these cells are not normal. And so that we call that carcinoma in situ. What questions do you guys have about the epithelium, about neoplasms, what makes something benign versus malignant? And is this pace okay for everybody? All right, we're going to keep going. We can always go back if we need to. Okay, so I kind of talked a little bit about the causes of malignancy and what makes them different from benign, but what are the actual findings on our pathology slides that we can see? Oh, these cells look malignant and they look scary versus these cells look more normal and we're not as concerned. So there are these like 3 or 4 or 5, I kind of grouped the last 2 together in my next slide, but there's these different features that we look for in signs of malignancy. The first one that we'll go through is pleomorphic cells with a loss of normal architecture. I think the last picture that we looked at does a really good job of demonstrating what pleomorphic cells look like, where they all have a different size and shape, and they don't look like they relate well to each other, and they don't have that nice predicted structure and just looking neat and well developed. So that's one finding that could indicate that it's malignant. Another one is an increased nuclear to cytoplasm ratio. So typically the nucleus is not that big, but in a cancer cell, think of what's happening. There's so much replication and cell division going on. They're going so fast with their cell division. They have like growth factors and transcription factors, and their DNA is constantly dividing. So their nucleus is actually going to take up more space in the cell compared to the amount of cytoplasm that's around it. And so a higher ratio of nucleus compared to the cytoplasm can also be a red flag for malignancy. A high mitotic rate. We just saw a cell going through mitosis on that last slide as well. So even just one, I would say, okay, maybe you can like your cells still have to divide, especially your epithelium is like constantly regenerating itself. But if you're seeing like a ton of cells that are all in mitosis and dividing, that is definitely not normal and would be a red flag for some uncontrolled cell growth. So we'll see an example of having multiple cells in mitosis within the same slide. And then 4 and 5, like I said, kind of go together. It's the loss of the basement membrane. You can't really see the basement membrane on true stain, like in that real picture that I showed. It doesn't have that nice outline dividing the epithelium from the underlying connective tissue. But in cancer, you do kind of lose that. And when it invades and it goes into the underlying stroma or that underlying tissue. And now that the cells are within that lower layer, they're not contained at the surface and are more prone to spreading to things like blood vessels in your lymphatic channels and things that can cause it to actually spread. So I'll show you examples of all of these, and because I know this is a busy slide, it's a lot of information. So this is the first one, the pleomorphic cells. Again, they do not all have the same shape and size and the way that they look. So like this one here is kind of like polygonal. It has a really big nucleus. It's, I don't know, got some other stuff going on. And then we jump over here and it's like, oh, this cell is, you know, looking a little bit more clear. And you don't have to really like be able to define at this stage what the cells look like, but just looking at this grossly, you would say it doesn't look like all the cells look the same. They just aren't. They have different you know, structures and they just look different. And the tissue itself doesn't have good organization as well. We shouldn't really see something that's this messy. Things that are healthy should have a nice organization, and you should be able to tell what the different structures are. And right here, you can't really tell like what these cells are supposed to be doing, what type of cell they are. And so this would be not a good finding because they're like losing differentiation. This is the example of an increased nuclear to cytoplasmic ratio. So again, like these cells, typically, like if we go back here, the nucleus is a lot smaller in a lot of these ones. And then here you can see just how big they are compared to the size of the cytoplasm. And a good like cheating way to tell if it has a high nuclear to cytoplasmic ratio is if they just look like a bunch of small blue cells. There's a couple of different types of tumors, especially like pediatric brain tumors or neuroendocrine tumors that are described as being like small blue tumors. That is due to them having a higher nuclear to cytoplasm ratio. And I kind of mentioned that before, it has to do with the rate of replication and the rate of division. And really what we're seeing here in the nucleus is the high amount of chromatin that's bringing out that stain. So that's two things. The third thing here is the number of mitotic bodies, or the cells that are going through mitosis. We can actually see sometimes if it's a clear enough picture, the phase that they're in. So I want you guys to just look at your screen and see if you can kind of like find all the ones that are in mitosis right now. And then I'm going to circle them in a couple seconds. So just kind of look and see what you can find. And here we go. I circled a lot of the ones. I'm not really sure what this one over here is doing. I didn't circle it, but it might be in mitosis because it kind of looks the same as the other ones. But like this one's pretty clearly in metaphase here. This one's in anaphase. It's already kind of splitting and dividing. Maybe, I don't know, this one is, maybe these are in prophase or something. I don't know, I can't tell. But they definitely look distinctly different than their surrounding ones. And you can see that chromatin stained really prominently. And then lastly, the invasion of the basement membrane and into the underlying tissue. So cells that would otherwise be contained to the surface are now not. And you can kind of see this here on, so this is showing a transition from like, these are the more normal cells over here. Again, we have this nice single layer of cells that are down at the bottom. And then we kind of have this progression of flattening out and spreading out as we go up. You can kind of see this pinkish light line underneath those dark cells that separate that from the underlying tissue layer. And then around this red line here is, I just arbitrarily picked this, but you can see it starts to lose its structure. And then all of these epithelial cells just are, you don't even see the basement membrane anymore. They're all invading down past that membrane. And this would now be defined as an invasive cancer as opposed to carcinoma in situ. And then so all of these things kind of play into the grade of the tumor. So grade 1 is something that it retains a lot of its differentiation. So it looks like the tissue it's supposed to look like. If you had a colon polyp, for example, the colon has a lot of glandular tissue. It's like secreting a lot of things into the lumen of the colon to help with your digestion. And so on a colon polyp, you might still see those preserved glands and the cells that look like the glandular cells that they're supposed to look like. And the cells will be uniform. They're not going to look super pleomorphic. And there's going to be a low mitotic count. So that would be a grade 1. It's the best prognosis. It's the closest to benign as you can get for it being a neoplasm still. And then grade 2 is kind of in the middle. It has a little bit more loss of architecture and loss of differentiation. And just everything kind of moderately changed with a little bit of a higher mitotic count. And yeah. And then grade 3 is the worst. You can see in this little illustration here, like we have a lot of cell variability. There's way less differentiation. There's actual nuclear changes with the nuclei being enlarged and have different sizes and shapes. And you can even see like the nucleoli and the vesicles in the nuclei as well, because they're so big. And then you have a lot of mitotic bodies and cells going through mitosis in grade 3. And as we see here, the prognosis decreases. The higher the grade, the worse the prognosis. So something that's grade 3 is going to be a lot more aggressive and harder to treat compared to grade 1. Okay, this is our last little mini break before we kind of wrap up the case. So I just wanted to see if you guys had any questions about those findings of malignancy and the grading system for cancer. This is a lot of kind of intricate pathology and understanding of like how cell division and organization works. So if you're following along with this, I'm really impressed. And please don't be afraid to ask questions because this is a pretty challenging topic. Okay, so back to a little bit for our case. The gold standard for diagnosis of cancer is a biopsy. We really can't say that something is cancerous without taking out part of it and really examining it under a microscope and looking at exactly what features it has that would make it cancer versus non-cancerous. However, in people who are asymptomatic and who have low risk and no history of cancer, we can do screenings to help catch things in earlier stages, like when it's maybe a carcinoma in situ or a very early cancer. So for cervical cancer specifically, the gold standard screening tool is a pap smear, where we don't take a biopsy necessarily, where it's like cut out and preserve the tissue architecture, but it just kind of catches the cells of the cervix and we put it in like a solution. So they're just kind of freely floating and not in like a chunk of tissue. And we're able to do cytology or cell studies to look for abnormal cells with those features that we talked about before, like how big is the nucleus? Are they, going through mitosis, that sort of things. And we can also look for high-risk HPV strains within these cells. So knowing somebody's HPV status, we don't routinely test for that. But in somebody who's high risk, we can test for it. And that can also change our management by doing more frequent screenings or being, like more a higher index of suspicion if we find abnormal findings. And then once we have a diagnosis of cancer, then before we really can treat the cancer, we have to know what stage it's in. So if it's spread to other organs or distant sites. So the way that we make that diagnosis is by doing a CT to assess for if it has spread or metastasized outside of its local area. And luckily, if it hasn't spread, then most of the time you can do a surgical treatment of the primary site. So if this is cervical cancer, then we can take out the cervix and the uterus and do a radical hysterectomy that way. And we can just eliminate all of the abnormal and cancerous tissue. However, if it is metastasized to other sites, then we would not be able to offer surgery because the cancer is going to just stay in the body and continue doing the cancer thing. So we would have to instead offer chemotherapy, sometimes can do what's called adjuvant chemotherapy or neoadjuvant chemotherapy before and try to get the tumors to shrink and to allow them to become operable. And then if they respond well to the chemo, we can do surgery and then do more chemo afterwards. But really that's the main prognosis for survival is if it's metastasized or not. And so doing this CT scan is important before deciding the treatment. So back to our patient case. I understand that this is not the most clear picture that I've shown, but I think it does a really good job of showcasing some important findings. So what would you guys identify as being some of the findings that we talked about on this slide? Let's start with the, if it's pleomorphic. Looking at the epithelial layer, do we see nice, uniform, evenly differentiated? And the epithelial layer, remember, this is this top layer here. I'm kind of moving my mouse along it. Do the cells that are going from the top to the bottom of this layer look like they kind of get that nice thin spread out look towards the top? What would you guys say? Seema's saying no. I agree. Yeah. They look like they kind of have that really jumbled appearance. They've got poor architecture, like Adam was saying. And so, yeah, these I would say called high pleomorphic cells. And then looking at the surrounding tissue, what do we think about the nuclear to cytoplasmic ratio? Again, I know they're not super zoomed in, so you can't totally see, but do you think that these look like a bunch of small blue cells? Yeah, Seema's saying it's high, so I would say it is high. We see a lot of blue staining the chromatin of the nucleus, so that would indicate that there's a lot of fast replication going on. Definitely, you're not going to be able to see mitotic bodies on something this zoomed out, unfortunately. So let's just say that we see a moderate amount of those. And then lastly, which again is important for just if we're defining it as being invasive cancer versus carcinoma in situ, do we see invasion past the basement membrane into the underlying tissue? Yes, perfect. You guys nailed it. We see this giant thing here coming down, and it's right around these blood vessels, and this is not looking good. This is unfortunately going to be, as Emanuela just said in the chat, an invasive carcinoma. So our final diagnosis here is a squamous cell carcinoma of the cervix. Squamous cells, I didn't really do a good job of defining what those are, but the squamous cells are all the different the type of cells that make up an epithelium. So if it's epithelium, then it is likely squamous for our learning purposes. And like we said, this is cervical biopsy, so we describe what type of cell it is, if it's carcinoma or if it's carcinoma in situ, or if it's benign findings, and then the tissue location that it was taken from. And then this isn't shown, but I did also want to throw in that additional testing revealed that she was positive for HPV-16, which could be consistent with her sexual history of not using condoms consistently and having multiple sexual partners, and a history of a different sexually transmitted infection. So likely what happened was with this HPV infection, she was more prone to developing these neoplasia type changes of her squamous epithelium that over the course of the 6 years that she wasn't being screened with pap smears progressed to this invasive cancer that would have maybe otherwise been caught if she had gotten the screening before. Great job. Okay, so now going back to our assessment and plan, now that we have analyzed her slide, we have a 32-year-old female with a history of high-risk sexual activity who presented with abnormal vaginal bleeding. Her pathology of the biopsy demonstrated features that are consistent with squamous cell carcinoma of the cervix. So our recommended plan is going to be to do a CT scan of the chest, abdomen, and pelvis for further staging, and we can use the information from that to then make a plan for how we're going to treat her cancer. Sound good? I almost always will include a patient update in these. However, I wanted to make you guys aware that sometimes in pathology, you don't always get patient updates because you are not the primary like provider of care, which can be both a good thing and a bad thing. So in the benefit of that is that I think like you have some built-in level of protection from the really hard instances of patient care where you have to like be delivering bad news to people and following them through really hard times. So there's a certain level of detachment and separation from these really difficult issues. But some people also find that they want to have the closure of, well, then what actually ended up happening to this person? Are like, what treatment did they get? Are they doing well now? It just is an individual preference, I would say. So I did want to include a little bit about pathology. So pathologists assist other physicians in the testing and examination of cells and tissues, which help make clinical diagnosis. And you can literally do this for any like part of the body. So the ones that I listed here, I would say are the most common for like blood disorders and for cancer, but they have literally everything. They are very vital parts of the healthcare team because they are truly the experts in knowing how to define if something is abnormal versus normal, and then what, the actual like naming and basically what they say is going to directly guide the further treatment of the patient. Despite being this very important part of the healthcare team, they tend to have very little direct patient interaction because a lot of the times these biopsies and these samples are taken for you by nurses or by doctors and then are sent to the pathology lab. And then the pathologist is already there and they just do their exam using the equipment that they have. So they work with a lot of technology that changes and very cool equipment and lab tests that really will allow them to know the exact reason for why a patient would be sick. Pathologists do enjoy a excellent work-life balance. I would say almost all of them are like a 9-to-5 type job. And they are just really nice people. Every pathologist I've ever met is so welcoming and passionate about teaching. And if you guys ever follow the like Dr. Glockenflecken videos on TikTok or Instagram or wherever you get your social media. He's like a physician comedian, and I'm always very impressed and feel very like safe in his pathology character because they just seem very like very kind and welcoming to students, especially because as a student, you always want to feel included. So that's just my little spiel about pathology. It is a really awesome specialty. If you're into like lab stuff and again want to have a nice lifestyle, then this might be a great specialty for you. So to become a pathologist, you do your 4 years of medical school, just like every other specialty that we've talked about. And then pathology residency is going to be 4 years long. And you have a myriad of fellowships to do afterwards if you would like to subspecialize. So there's things like dermatopathology, who would work with dermatologists in evaluation of skin disease, hematopathology, which would be looking at blood disorders and blood cells and their morphology, renal, looking at the kidneys, transfusion medicine, surgical pathology. And surgical pathology is also very cool because they will take the samples from their cancer and look at them while the patient's like still on the table and under anesthesia. And basically everyone in the OR, like the surgery team, is just kind of like waiting for the read from pathology on the sample that they've sent. And then that can further guide if like what they're going to do for the rest of the operation. So it's a very real time, real like good or like high stakes and important role in surgical treatments as well. Neuropathology, one of like the nicest and best professors at the University of Iowa, is a neuropathologist, and she's just so passionate and so sweet, and I love her. Peds pathology, genetic pathology, clinical informatics and data science. So if you're into like computer science and that kind of thing, it's not my thing, but if you're into that, then there's definitely a place for you in pathology. And then also a little bit of crossover with like the legal system as well, medical examiners who perform autopsies and forensic pathology as well, are fields that are, I would say, unique to pathology specifically. And that's just a selection of the ones that I thought sounded interesting, but there's even more than that. So that's my little chat about pathology. Hopefully you learned something new about this specialty. I don't even think I knew that it existed before I was in medical school, and it is definitely a very enticing field to be in. So consider that. These are my sources, and I just wanted to let you guys know that in this soap note and quiz, if you needed to go back to any other slides, I'd be happy to help you with any of the questions, or if you just have any other general questions about medical school or applications or anything in this presentation so far. I'm not personally going into pathology, but I can also try to answer questions about that specialty. I just wanted to thank you guys all for being here. I hope that you enjoyed this presentation. I know it was a little different than what we normally do with it being flipped and having the assessment and plan come at the end. But I hope that you liked kind of getting to play doctor a little bit and see what that would be like as a taste of being a pathologist. So yeah, that's pretty much it. Thank you guys for coming. I will be around for questions and until everybody's kind of drifted off of the call. Yeah, thank you all for coming. It was great to see you guys. If anyone's applying, I know last week we had somebody who was applying and had just submitted their AMCAS. So good luck to you in this application season if you are. I'm thinking about and praying for everybody that you've got, you know, lots of secondaries and lots of interviews. Oh, Seema's asking, what chemotherapy would we give to our patient? That is a great question, and I do not know the answer. I think it would really depend on the specific cell targets that are available, and I just don't know the first line chemotherapy for squamous cell carcinoma of the cervix. So yeah, I wish I had a better answer for you. The only ones that are coming to mind as like possibilities would be like a cisplatin or like a platinum based, just because I know those are like really strong. But I really don't know. Sorry about that. Do you have like a background in oncology or something that would make you curious about this question?
No, I just did like drug discovery type of research during undergrad. So
Okay. So
yeah,
you might actually know better than I would.
Yeah, I was just wondering like what happens once you get the results from the CT scan? Like, what are the next steps in managing the patient's disease?
Yeah, that's a great. So I think I can maybe help a little bit better with that one. So if they're metastasized to other organs, then we would do neoadjuvant chemotherapy, which I don't know the specific drug, but they would go through X amount of cycles of that chemo. And then what they would do is rescan and restage them to assess their response to the treatment. And if the chemo worked well and they were able to shrink down all of the tumors, or, hopefully it wasn't like just everywhere in the whole body, because there is a certain like level to which if there's cancer everywhere and it's just not going to be a good chance of recovering, then we would probably have a conversation about goals of care and bring up the option of potentially just not treating and doing palliative care. But if it is either patient preference or a good chance that there could be recovery from those metastases, then we would restage them with a new CT. And if everything is improved, then we could actually go back and do the surgery and try to get the rest of the cancer. And then for any potential remaining cancer cells, we would do adjuvant chemotherapy after the cancer to try to just make sure that everything is completely gone, and then do maintenance scans and screenings to ensure that they can remain in remission is kind of the timeline for what you would do if they had metastatic disease.
Oh, okay. Thank you so much.
Yeah, no problem. Great question.
Thanks.
I
Bye.
do think you're the last one. So if there's anything else I can do, otherwise, it was great to see you. Thank you for asking.
Yeah, no problem. Thanks. See
Yep.
you next
Okay.
week.
Yeah. See you soon. Bye-bye.